Just by way of introduction, for those who are new to these conversations, my name is Dr. Rich Joseph, and I had the pleasure to serve as the medical director at the Center for Community Wellness at Sportsman's Tennis Center in Dorchester. It's a wonderful partnership between the Brigham and Sportsman's to bring sort of health education and engagement into the community. Sort of out of the large academic center into the community. And so one of the things that has come out of COVID in particular are these community conversations that we're trying to host more often to sort of tackle challenging issues that are sort of intersection of healthcare and medicine and race and politics. And, we had previous discussions around COVID and the vaccine in particular. And was trying to figure out the best next time to sort of host a COVID-specific forum, and figured there's no time like the present to re-engage with this topic. And I know that people in many ways are, kind of sick of talking about COVID in some ways, but also recognize that it's so important and it's changing and the situation is evolving rapidly. And so we need to sort of make sure everyone is up to speed and well informed. And we have
You get it?
we have three
Getting it?
we have three amazing panelists tonight to sort of help provide that information. And so I'll introduce them now. And so we have Dr. Lisa Cosimi, who is a doctor at the Brigham, specializes in infectious diseases. And then we have Dr. Lindsay Baden, who many may recognize, because I did the conversations with him earlier about the vaccine trial in particular at the Brigham. He's also an infectious disease specialist from the Brigham and works particularly in early vaccine development. And then we have Dr. Paulette Chandler, who's been involved in the work at the Center for Community Wellness for a long time, and has also is a primary care doctor at the Brigham, and is sort of engaged in frontline work of speaking to patients about COVID and the vaccine sort of every day. And so it's a wonderful group of people here with us tonight. And so sort of just I always have a bit of a scope for the conversation and try to lead the conversation with some questions that I've sourced from other people before we start, but would encourage people to chat me as we talk, because I'm not going to hit on everything that you guys want to hear about. And so I would really encourage your questions, and if it's okay when you chat me, I'd love to also just sort of call you out and have you ask the question and not just me, because I think the more that we can make this a bit of a town hall and not just me sort of having this conversation, the better. And so I thought what we would do is start initially with a bit of the latest science around sort of SARS-CoV-2, the actual virus that causes COVID, because I think it's, well, maybe a bit sciencey. I think it's actually really critical to understand sort of everything about the vaccine and the trajectory of COVID and how it's evolving. And so just to start, like sort of naming this new surge that we're in right now, which is quite distressing in many ways, but I think was somewhat anticipated in certain ways too. And so hoping to just hear from, maybe like Lisa, you could start by just sharing maybe your thoughts on sort of what's driving this new surge. Like what's the deal behind this new surge?
Yeah, well, first of all, thanks for having this conversation tonight, and I'm very happy to be here. And I think happy to be here in this conversation. It's hard to be back where we are right now. I think it's distressing to everyone to see this surge. On the one hand, we thought that this could happen, and we sort of predicted that there would be another wave. I think, it's a bit science and it's also a bit human nature. As we got control of everything, everyone social distanced and everything shut down, and we really sort of got control over things in the spring, and then it was warm out and people got used to socially distancing, but getting together again, but getting together outside. And, so we're gathering and getting together for barbecues and beaches. And, what we learned and have learned about this virus is that it doesn't transmit as well outside. It doesn't transmit as well if you're masked. It doesn't transmit as well outside. It really takes closed settings to increase the risk. And people want to see their family members, people want to see their loved ones and their friends. And as it's gotten colder again, and we've continued to gather inside, and restaurants have moved inside, and the holidays have come, and people want to be able to see their friends and families over the holidays, we're seeing the surge again.
Yeah,
yeah, go for it.
I think that, as you say, Lisa, we just are tired of COVID, and we're tired of COVID restrictions, if we can put it that way. And then we let down our guard. And this is a highly transmissible respiratory virus, period. So we let down our guard, it doesn't. So I just wonder if there's just some of the reality of our, that we're all dealing with, where I'm just tired of it.
Mm-hmm.
But that doesn't stop it from spreading as we're watching.
Totally. Yeah. And I think, all of us sort of understand, or at least intuitively get that, like, respiratory viruses tend to be worse in the wintertime. And I guess it gets to a bit of another question around, sometimes we're still hearing a little bit about sort of the respiratory symptoms that people are getting from COVID. And we understand that people, some people get really sick with those respiratory symptoms, and they sort of end up in the ICUs, and that's really horrible. But, like, what else are we, like, learning about the actual virus itself and how it impacts the body that, is maybe different than the flu, right? Because some people get really sick with the flu and end up in the ICU too. So, like, what's the big difference here?
Yeah, so I think the beginning symptoms of this virus can be like the flu. And there are some people that become infected with this virus and, have very mild symptoms. Young 18-year-old might have very mild symptoms, runny nose, sore throat, headache, may not have thought twice about it. But I think what we have learned about this virus, that in certain populations, folks over 60, folks with diabetes, folks who are obese, heart disease, that this virus can cause a really extreme sort of inflammation in the body and very severe illness, such that people come in almost like we used to see a severe bacterial infection, a sepsis, with low blood pressure, but also the severe respiratory pneumonia, much more severe than what we see in the flu.
Right. And the other aspect of it is that the damage that it causes to the lungs can be long lasting. People leaving the hospital, some of them are still oxygen dependent. They're months out from this infection, and they're still on 2 liters, 3 liters, 4 liters of oxygen. And also the damage to the heart muscle, the damage to the brain, that fogginess. People have confusion, difficulty processing thoughts, lasting for months, not to mention the loss of sense of smell. We have some folks, they still haven't recovered their smell, and they're 3 or 4 months out from their, first infection.
I think that's a really important point. And, so much of the press and the data focuses on hospitalizations and deaths. And, you have the press right now going, oh, look how many cases we have, but we only have so many deaths. But what it really doesn't report is this long-term impact. And I wish that's something that it would be captured better, is the percentage that really are impacted for months.
Yeah, I think it's a really important point, because I think that sort of distinguishing as somebody, it is different than sort of the flu in a lot of ways, right? It's a very, very different type of disease that people get in a lot of ways, and it's been shown to sort of affect sort of blood vessels everywhere, which therefore can affect organs everywhere, right? So it's different than the flu. And I think, in our discussion too around sort of treatment and the vaccine and all that stuff, it's helpful, I think, to make sure people understand, like, this is actually very distinctly different from the flu, even though there is some symptom overlap.
Rich, I think what's in part related to that is we get the flu every year. So next year when you get the flu, it's related to last year's flu. So even though the vaccine may not be perfect, you still have some flu immunity because you've seen it before. None of us have seen this virus. So we're all susceptible to it, and therefore it really can infect all of us and then infect all of those around us, because we have there's no prior immunity from last season. And I think that also facilitates it just being so explosive, which was what we're seeing.
Yeah. And so let's sort of shift a little bit then to, we talk about how devastating it can be the treatment for this, or sort of what the options are for treatment right now, I think that we have maybe some of our politicians saying that it's look, we have all these different treatments, and I got the best treatment, and this is great, and we can get over it very quickly. And I think that is dangerous in a lot of ways. And do all people have access to those treatments? So I guess the question is, like, what are the treatments right now, and are all people being treated equally? Either any of you guys can take that.
Well, we know that all don't have access to the treatment. We think about President Trump, he got Regeneron and some other treatments. Governor Christie got, Regeneron, because people are like, oh, surely Christie's going to die because he has all those comorbidities. But, and then Ben Carson got the treatment, and Giuliani sitting up in Georgetown. So we know that individuals don't have access to these fancy treatments, and they will not have immediate access. So we're going to need other interventions besides these expensive treatments to halt the spread of the vaccine, halt the spread of the virus.
Yeah, I mean, and so I would just add to that, I think the hope in the spring was, let's flatten the curve until we get to better treatments. And the reality is that, yes, we know a lot more. We can treat people better. We are definitely caring for people better once they're in the hospital. There's remdesivir, which is an antiviral. There's dexamethasone, which is a steroid, which we know helps. We know that preventing the clots, which is something we didn't talk about earlier, but giving medication to prevent clotting can help in certain individuals. The monoclonal antibodies like Regeneron are now available. The problem is there's not anything, these are all intravenous medications, or things that should be given in the hospital, not the antibodies, but are an infusion. We don't have for example, a Tamiflu, which is what you would give to someone early on when they are infected with the flu. We don't have something that we can give to people right when they're infected. And there are limits to what's available with the monoclonal antibodies. We have been granted in Massachusetts a set number of doses of these antibodies right now, and they're not going to be available for everyone at the moment. Once people get into the hospital, this was, Rich, something you had, a question you had thrown at me earlier. Once people are admitted to the hospital, it's very clear, and that's very guideline driven, what medications are available. And those are widely, so the first three I mentioned are available to everyone once they're admitted to the hospital. But before that, it's difficult still. Lindsay,
of course, if they get admitted to a community hospital, they may not even have access to remdesivir. Yeah. So, I mean, it's variable in terms of which hospital you're admitted to, what therapies are available to you.
And I think, as Paulette and Lisa, as you were saying, when we look at some of the celebrities, if you can walk out to your front lawn and Air Force One fly you over after your personal medical unit says you need more care. So you're getting diagnosed early, you're getting treated early. And that makes a difference than if you wait till you're really sick and things are more advanced, because some of these medicines, probably the monoclonals, probably work early and may not work late. And that means that somebody's paying attention to what's going on. Right. And then, as you say, Paulette, not all hospitals or places are going to have all this stuff. So, but the ability to sort of know you're infected, and to have somebody sort of looking over things early to know if something needs to be done, I think is important too.
Right. Well, let's talk about how you know you're infected, I guess, and talk a little bit more about testing in particular. One of the questions I've gotten, and even myself sometimes have a hard time answering for people, is like the difference between the different types of tests that are out there now. So, the PCR and the rapid antigen test. Lisa, maybe you can start by helping us understand sort of what's the difference between these two, and like where are we sort of with testing generally?
With testing, well, we're still not doing enough testing, I would say. And it's taking too long. But the difference between the PCR, so the PCR test is what most people will have had if you've been tested in any of the big testing sites, any of the Stop the Spread sites, any of the sites associated with most of the community testing around. And that's going to be the swab either in the way back, the brain biopsy, the way back in the back of your nose, or more commonly now is a nicer front of the nose swab that a lot of the sites are converting to. And that will test for a piece of the RNA virus, the genome of the virus itself, or the RNA of the virus itself. The antigen test, the rapid antigen test, and the one that's most commonly talked about now is by a company, or the test is called Binax Now. And that tests for the protein. So that will look for what's the spike protein, which everyone has probably heard of at this point. The PCR test is the most sensitive. And the antigen test, although less sensitive, it's more rapid and what seems to match fairly well with the PCR test in folks who are symptomatic at the time.
So does that explain sort of the difference in sort of how long it takes for the test to come back? Because that's also sometimes an issue for people. They're like, why is this taking so long? Sometimes I can get it, if I go somewhere, I can get it like on the spot basically, or a few hours later. Other times it takes a lot longer.
Yeah, I mean, so there's a few different issues with the testing. So some of it is the type of test that's being run with regards to the rapid testing, sites that can do, there's some care, CVS's or Walgreens that have a machine and they can run it faster. With the larger sites, so places like Quest, so that when labs are when the test is being sent to a large lab, some of those labs serve a region or the nation and maybe doing, tens of thousands of tests a day, and are running into things like pipette shortages in pipettes, shortages in reagents, and are just getting bogged down at this point.
Yeah, that's helpful to understand. So I guess one of the things a lot of people are wondering is if they get a test, they get a negative test, right? Does that sort of give a bit more clearance for some permission to, with the upcoming holidays, to attend an event with family, or, should people who want to go hang out with their family get a test, and if it's negative, we give them the okay?
So this is where I would say that it really depends on what you were doing prior to the time you got that test, right? So if you were quarantined for the 14 days before you got that test, I will even say the 7 days before you got that test, you get a test and it's negative. You've had no exposures whatsoever. In that case, you're probably safe. You haven't had any exposures. Fortunately, that's not the life that most of us are living right now. And so that test is only going to reflect sort of the virus in your body at that time. So if you've been out and about or working, or if you had an exposure and didn't realize it, maybe 3 days earlier, 4 days earlier, there may be just enough or just a little virus in your body. It's not replicating enough yet, so that test may not catch the fact that you're about to have detectable virus. You're about to be sick with the, with the virus. So that's the trade-off. So it's not perfect at all. So you can't just say I had a test, I'm good to go.
And what I find complicated about it is, what about the people around me? My kids, my wife, that the problem is the contagion is such that anyone can bring it into my circle. And then what do I want to do when I go to an event in terms of what I bring to them or what any of them bring to me? And I think that right now, and I think it's a different conversation back in July and August, when the case rate in the community was so low.
Yeah.
Now, I think right now the case rate is just so high that, at least in my own life, I'm trying as hard as I can to be in a bubble and have my family be in a bubble at least for 2 to 3 months, when I think we may get to a better place. But right now, the infection around us is just so high. And it's not just me, it's everybody around me and everybody around the people around me, if that makes sense, given how transmissible this is.
Sure. So it sounds like, you know, the testing helpful, but not perfect in many ways. And, you know, if you get tested, you still may have the virus, even if it is negative, because it's sort of maybe an early stage of the virus that's not even caught by the test. And so it sounds like,
And it gives you a false sense of security.
Right.
Because, I mean, I think about this poor lady. She got her test and then she said, okay, I'm going to fly down, visit family. She visited family. She came back. As soon as she was picked up at the airport, she, you know, was having fever. So they took her to get her test. She was feeling weak, even too weak to drive home. But she thought, okay, it's COVID. It's probably COVID, but I'm going to get over it, because most people do get over it. Unfortunately, 2 days later, she's dead, and she died in her home. She didn't make it back to the emergency room, because symptoms can progress very rapidly. Most people don't die, but the elderly, they can develop symptoms that progress very rapidly, and others too with compromised diseases. So
yeah.
it's vulnerability, but also don't be comfortable thinking that your negative test is protection from the disease.
Right. I want to sort of harp on that a little bit around sort of the severity of disease a little bit, right? We were talking about testing, but you were mentioning someone who sort of rapidly progressed, right? And so do you have any more sense of like what types of people or what conditions put people at risk to rapidly progress like this? Like, you know, seen some articles about like different blood types and all these different things that like people are, you know, so many different ways you can look at people, you know, from a research lens. Have we discovered anything new around who's most susceptible to this?
Age. That is the most robust one, unfortunately, across continents and across time. You know, the blood group one, which Rich, I think, is curious, but that's been an age-old one for infectious diseases. So I don't quite know how robust that really is. But I think age is the most important. And then there's susceptibility in terms of people with underlying heart disease, lung disease, obesity, diabetes that increase the risk for getting sicker.
But there's definitely been a great interest in the blood type. Patients are calling nonstop now to wonder what their blood type is. But age is definitely a bigger predictor than.
Yep, for sure. All right, so let's get back to testing. You know, one of the challenges obviously has been for essential workers in particular, and you know, needing to get testing regularly, ideally in an ideal world. And what's sort of the hang up with that? Why is that not possible? And you know, what could we be doing better?
Yeah, I mean, it's so challenging because again, we would think that by now we would be doing this a little bit better. But it really does come down to there's not enough, there aren't enough testing sites. If you want to go get tested, you have to, so if you're an essential worker and you're working certain hours, you may not be able to go get tested during those hours. You may not be able to get your family members tested during certain hours. And to be tested, I mean, ideally you'd be tested frequently enough if you were exposed to be able to know if you were infected or not. And most people just don't have that. It's just not convenient enough to be able to do that. So I'd say that's one of the big challenges. And then there's folks that are either at home, so they're not able to go out, or partially homebound, so not able to go out and get tested, even though they might be exposed in their home.
Well, it would be remiss of me not to sort of, you know, capitalize on what you're just saying and sort of highlight the awesome work that you're doing, Lisa, at the Brigham and around home testing. And I think that would be something for all this entire group that's joining us tonight to hear a bit more about, and you know, how you got going with sort of even developing home testing and what might be an opportunity for participants here to even get involved in as well, if of interest.
Oh, sure. Yeah, so along with two colleagues of mine, Ann Woolley and Deb Hung at the Brigham, we are running, it's a research study, but it was really started with the idea that we wanted to build capacity for home-based testing for COVID-19. And it stemmed from a time back in April when all three of us were taking care of patients in the hospital and just seeing people come in so sick and just really so frustrated with the lack of testing at the time, that we just started to brainstorm, what can we do? How can we get more testing out to the community? And it happened to be at the time where the Broad Institute was scaling up their massive testing operation. You know, they're now doing 100,000 tests a day. They're doing all the Stop the Spread sites. And we just started to, put our heads together and say, can we try to figure out something to do at-home testing? And so the idea is to enroll 10,000 individuals from the greater Boston area. And we're sending kits to people's houses once a month. The kits contain the anterior nasal swab that Stop the Spread sites are now doing, and a finger prick to do antibody testing. And we're testing once a month for 6 months. And people can also request a kit if they become symptomatic during it. So if you, 2 weeks after you do your monthly test, you have symptoms, they can request a kit and we'll send it out overnight. And really the idea is to try to get both a representative sample of where infection is and where there are potentially new hotspots that are coming up in the community. And also really try to increase the access to testing, because although it's a research test, it's the same test that is being done by the Test Boston site. The Stop the Spread sites. So the hope is that if we can prove this works, we can push towards eventually having more clinical options. You're more having an option for a clinical test at home.
Yep.
So that's the idea.
No, it's amazing, and I'm glad you were able to sort of describe it a bit more here tonight, because when I hear about that, I mean, as you said, it is a research study, but it also is like providing like an awesome public good in a lot of ways. For I think about people who are essential workers, people who are homebound, and I think can't get access to either frequent testing or to a testing site itself. And wouldn't that be wonderful if people could access it from sort of the convenience of their home? So, yeah.
Also, if you do have a positive test, we have another trial, the vitamin D trial, that you may consider thinking about enrolling in, where if you have a positive test and it's positive, within 3 days, you can think about participating in a vitamin D supplementation trial where you'll get vitamin D for a month, and you'll see whether it reduces the severity of illness. And there'll be more information about that vitamin D trial for reducing severity of COVID infection that'll be rolling out next week, just as another thing to think about.
That was interesting. I didn't even know that was happening. And I think, one of the things that we do on these conversations is to, and as we talked a lot about with the vaccine trial and stuff too, was like, how do we not only have the dialogue, but get everyone sort of engaged in the science of trying to figure out how to best deal with COVID, right? And that's sort of a collective community effort as much as possible. And so appreciate both of you, sharing those opportunities. So just in case, if people are interested here, like where, Lisa, just for the Test Boston, where do people go get information about that stuff?
Oh, sure. It's so there's www. I'll put it in the chat.
Yeah, put in the chat. And Paulette, same thing to you if you don't mind. Just so people have the information, people can read about it.
Unfortunately, our website is not up yet, but the
technical difficulties.
Okay. But I'm going to put the name of the trial at least. So
okay, cool. Thank you.
I should mention, this is outside of the research trial, but the FDA today just approved the Pixel. There's a company called LabCorp, which they were the first company to have an at-home test, and they approved their at-home test to order it without a physician right now. Oh, wow. I know nothing about how much it's going to cost. I would expect, based on what their other tests cost, that it's probably going to be cost prohibitive for the majority of us. But there are sort of lights at the end of the tunnel that people are seeing that this is important, that these tests have to be easier.
Right.
There has to be a way to be able to test easier.
Right. So let's now that we got a bit of an update on testing, which was super helpful, and still obviously a long way to go to sort of make that as best as possible. Let's talk a little bit about the vaccine as well, since that's also a hot trending topic now in the news. And I thought maybe we could just start by having Lindsay just sort of orient us a little bit around, it sounds like there are multiple types of vaccines out there. Which ones, what do we know about them? What's sort of the first type of vaccine that's going to be, approved for use?
So as we've talked before, there are two vaccines that have shown that they work recently, and we've all seen them in the news, the Pfizer vaccine and the Moderna vaccine. And I'm heavily involved in the development of the Moderna vaccine, and the other ones through the government industry partnership. But the Pfizer and Moderna ones both showed about 95% efficacy in preventing clinically symptomatic illness, which is, really encouraging and amazing for vaccines. These are large studies, 30, 40,000 people per study, and a couple of hundred events. And I think in the Pfizer was 162 events in the placebo group and 8 in the vaccine group. So if you got the vaccine, almost nobody got sick. And the Moderna one, I think, was like 185 versus 11. So again, if you get the vaccine, almost nobody gets sick. And that's really encouraging. Today, the FDA met and discussed the Pfizer one, and the advisory committee voted to move it forward. So I suspect in the next day or two, the FDA may make a formal determination. And once that happens, then vaccines have been manufactured. So then it gets distributed to the states, and the states decide how to deploy it to the communities.
Okay. Yeah, it's helpful to know sort of who makes the decisions, right? We'll talk a little bit more about that. But so if I get the vaccine, right? If I get the vaccine, does that mean that I don't get infected with the virus, or does that just mean that I don't get symptoms? And I guess if it's the latter of those, right, can I still then infect other people, right, even if I get the vaccine?
So that's a great set of questions, because you can say, is it that I don't get sick? I don't get it. I don't get it at all. And can I transmit it? And what we know is that people don't get sick. We haven't yet looked to see if it prevents people from getting the virus. And we've not yet looked to see about shedding, which is the issue of, can I give it to others? So those are things that we'll learn more about soon. But right now, what we know is just about whether or not you get sick.
Which I think is a really important distinction to make, right? And I guess the question that arises for me, and I'm sure others here then, is like, how do we then expect, if we can still get the virus and shed the virus and so still potentially be infectious, how do we expect, like, why should we get the vaccine anyway? Like, how is this going to work? I guess that's my question.
I mean, I think that there are different problems. We're trying to solve a lot of different problems.
Okay.
And to some degree, I would say the most important problem is, I don't want you sick and in my hospital and in my ICU. I don't want that. So in that sense, the vaccines are terrific because they prevent you from getting sick. What we don't know yet, and it's not that it doesn't do it, it's just everything is moving so fast in COVID time that you wind up looking at the most important thing first, and then you work your way backwards for the other things, is whether or not it stops you from getting it at all. Because part of what you're getting at is, do we stop transmission in the community so that it's not spreading anymore? And that's really where we want to go. I think that's probably true, but the science hasn't been done yet because it moved so quickly on the most important thing, which is trying to stop people from getting sick. And when you look across the country and our ICUs are full, our hospitals are full, and people are taking parking garages and turning them into field hospitals, I think trying to stop people from getting sick, I think, is real important.
I think really important conversation, sort of just to, people understand sort of what we know about the vaccine, what we don't know about the vaccine, right? And, I think one of the things that we try to do in these conversations is like, be very clear that we don't have all the answers. I know all three of you are experts who are brought in, but none of us have all the answers for this. And so I guess, I have a few questions, more like specific questions about the vaccine itself. So I guess, if you've already had COVID, do we know anything about how, like, the immunity that you get from a prior, like, having COVID versus what you would get from getting the vaccine?
Yeah, it looks like the vaccines can bring out immunity that looks similar to people who recovered from COVID and maybe a little bit stronger.
Okay.
And we also know that in the vaccine studies that 2% of people in the studies had already had COVID. And so that the vaccines worked fine in that setting. So it didn't cause any problems in people who had COVID already.
So if you already have COVID, like, do you need to get vaccinated?
Well, that's we don't know the answer to that. The current recommendation is probably going to be to just ignore whether or not you've had COVID, because one, it gets complicated to assess. And number two, we don't know how strong is that immunity. And so we don't know. We know how strong the vaccine immunity is. We don't know how strong the COVID or the natural infection immunity. And it's more what we don't know than what we do know.
Okay. And then we'll talk a little bit about side effects around the vaccine. I think, people have heard about side effects from, whether that is sort of the polio vaccine, or like there have been, stories that have come up over time around, long-term side effects. And do we really know enough about potential long-term side effects with this vaccine?
Well, I mean, I think that a couple of things to just be aware of. You can't get COVID. There is no COVID in it. There's no live virus. There's nothing like that. So that, like with the polio vaccine or the smallpox vaccine, there was live virus. There's none of that. This is all synthetically made. You can't get COVID from it. But with COVID, nobody has had COVID we've had a year of follow-up, because COVID didn't exist a year ago. So nobody with a COVID vaccine has a year of follow-up. In fact, it's a couple of months, 6 months of follow-up. So we don't know the implications a year or two or three from now. There's no reason to believe that it should cause any unusual side effects, but you're right, we don't have the data. What we can say, and I think Paulette brought this up earlier, when you get COVID, there are all sorts of long-term effects from COVID, from the lungs to the noggin, so that we know when you get COVID, it can cause a bunch of trouble. There's no reason to think the vaccine should do anything like that, because it's just different. But that's sort of what makes sense. Most vaccines, we see side effects in the first month after vaccination. They really don't cause side effects 6 months later. But we don't have anyone who's had a vaccine and is a year out from the vaccine. So it's hard to answer that question.
Right. Makes sense. Just sort of trying to get all the facts straight and sort of understanding what we know, what we don't know. And so I think just like the honesty around that is really important. Just very tactically, how many doses of the vaccine do people need to get? And if there are multiple doses, am I going to be immune after just one dose? Or because I think this is a challenge, right? If there are multiple doses, it's going to makes it harder.
Yeah, it is going to be a challenge. No, they're both 2-dose vaccines. One is 28 days apart. The other was 21 days apart. Protection looks like it kicks in a couple of weeks after the first dose, but we don't know how good it is one dose alone, because everyone who got one dose got a second dose. So we only get to see the one dose to day 21 or day 28. So we don't know if one dose is enough. We'd like it to be, but that's not the way. The study looked at 2 doses, and it's 2 doses that worked at the 95%, efficacy. So we don't know what one dose does.
Okay, makes sense. People, 2 doses.
Rich, is the chat open? Because I was trying to put something in the chat about the vitamin D trial.
The chat is open, but maybe if I make you chat it to me, if you can chat to me, then I'll chat it to the whole group. Let's do it that way. Yeah.
Perfect.
Yeah. I was going to ask about, in particular, again, we're talking about some of the data that we're seeing right now from these trials, right? And I think in particular for this group that we're talking to tonight and these conversations that we host, one of the important pieces is like how many, particularly like people of color, are in these clinical trials? Like, does this trial represent sort of the broad swath of the population, so that people, you know, who are considering, like, or hesitant about getting the vaccine or not sure, like, do they know that they were represented in these studies?
Yeah, I mean, the studies worked hard to try and represent the nation, and in some ways it did work well. Some ways, we got to do it better. But I think both the Pfizer and the Moderna trials had about 10% Blacks, 25% Latinx, about 40% were people at high risk, meaning seniors or have some of the medical conditions we talked about. So tried to enroll the kinds of people who get COVID and get sick from COVID, because that's where we're, need to make sure it works. And that's where the epidemic is across the country and in Boston. And so it needs to represent where the virus is circulating. So those numbers give a sense of what's been included.
And I was hoping, Paulette, I know you were really involved in sort of helping to help bring communities of color and people from all over the place involved in these trials. And, curious for this group to maybe just, if you could hear a bit, some of your reflections maybe on sort of what the challenges were there and what you took away from that experience.
Right. So, yeah, we really did want the trials to, specifically the Moderna, because I work with the Moderna trial, in terms of educating the community and making them aware, because, awareness about a trial is important for thinking about participation. And as we reached out to communities, we wanted to acknowledge the past experiences of people of color in healthcare and in society, and the distrust. And there was great distrust expressed by many in the community, especially Blacks and others, vulnerable populations, about whether they would have side effects, whether they would be infected with the virus, whether
FaceTime video.
1 second.
As a guinea pig. And I think about some people, they say, oh, I don't want to be a guinea pig, and I don't want to see Tuskegee repeated. But those same individuals have also expressed, even though they did not participate in the trial, they said, I'm ready for this vaccine now. As one guy told me, he said, Dr. Chandler, when that vaccine becomes available, I'm ready. I'm going to be first in the line. And this is, older Black gentleman. So even those that did not participate, some of them were willing to become champions. Like one lady said, I can't participate because I'm thinking about getting pregnant and I don't want my baby to be affected by a vaccine that I don't know the long-term side effects of, but I will encourage other people to participate. And we did have many people that were willing to be champions. Others that signed up, they went home and brought other family members to enroll. And others said, I've got to be a part of this. My community has been devastated by this virus. I want to be a part of the solution. So we had a lot of good discussions around past experiences, police brutality, all the different things that people think about in terms of how they're being treated and how they don't want to be mistreated by participating in a vaccine trial. So these trials are important. We do want people to engage, and there are more trials coming along. So this one was successful in recruiting a diverse population, but it required a lot of conversations. So we want to continue that conversation, even as we think about rolling out the vaccines, ensuring accessibility to vulnerable populations for the vaccine, as well as improving access to testing. We know certain pockets in Boston are still having low rates of testing, even though their numbers are surging like crazy.
And I think, Paulette, You're hitting on one of the key issues, which is trust. And will people trust the vaccine? And what are we having enough of a conversation to get, to answer people's questions and concerns so they can understand where this fits in and improving their health?
And I wanted to, as a great segue into sort of having a question from Tony, who's the executive director of Sportsman's and someone who I work very closely with. Tony, I see that you're unmuted. Would love you to chime in.
Well, I think, first of all, thank you all for being here. This really means a lot to us to be able to host these kinds of forums. and to have the CCW in general here in the community. And Paulette sort of, Dr. Chandler began to sort of speak to it in terms of how we build champions in the community that can help to build trust. But I was trying to understand sort of what the Brigham sees, how the Brigham sees its role in being able to help to build the trust of the community to actually take the vaccine. I was curious to hear that that roughly 10% of the trial participants being Black was considered to be a success. So I guess I'm just trying to understand, like, how are you gonna, what would you consider to be a measure of success in communities of color? We were on a conference call, and I think I heard someone saying on the news today, that how do we make sure that Dorchester gets prioritized ahead of Wellesley when you're talking about distributing the vaccine, because of when you look at the population in the two communities. And I guess my question would be, you know, the Brigham sits where it sits, and there's Dorchester, there's Brookline, there's all these communities, but what does the Brigham see as its role, and how can the Brigham help to really build the confidence of people of color to take the vaccine when it is available?
I mean, I'll start off and then I'll let Lindsay talk about more about distribution plans and operationalizing distribution. One way of building trust, of course, is to have these type of conversations. Two, to make sure there's some reciprocity with, you know, we're eager to have individuals participate in our trials, but we also want to make sure that we're building ways that we're investing in the community. One way we've done it is through like our community health centers. For example, Brookside was one of our recruitment sites. We did food distribution, voter registration, census, housing advocacy, because housing is a big issue. We help people handle evictions. And now and of course with Southern Jamaica Plain Health Center, we have a summer job program for high school students. We have our Students for Success program, job training at the hospital. We're thinking more about how can we help with the economic side of people's lives too. Job training, access to jobs where they're not necessarily in low wage paying. So those are some of the ideas that the hospital is wrestling with. And in terms of accessibility to the vaccine, we are aggressively working on that. You know, the vaccine will be distributed in a lot of different sites throughout the city. That's the plan and vision. We are working with Massachusetts League of Community Health Centers to orchestrate how the vaccine will be distributed, but also working on acceptability, because we know there's a barrier, there's a hurdle to think about accepting some injection for, you know, something that's been developed very rapidly, and we don't have long-term side effect profile information yet. And we will be doing a town hall for our community health centers next Wednesday, where we'll be working with staff members and city and state officials around developing good plans for distribution as well as acceptability. From that town hall, there's a toolkit that Massachusetts League of Community Health Centers has developed in collaboration with others that will have these homegrown conversations within the community health centers. And then they'll be rolling that out to patients. And of course, our patient and advisory boards are involved. The community advisory boards are involved with the community health centers. So there are a lot of different strategies that we're using to ensure access to the vaccine and address concerns and fears about receiving the vaccine.
You know, but Tony, I think you're right. We have to do better. You know, just if the studies have to represent our communities and the communities who have the illness, or else we don't know that it applies to those communities. Mm-hmm. And we've been able to do it to a point where we understand, but we still got to do better. Mm-hmm. And then the issue of distribution is going to be complicated in that initially the supply, I don't think, is up to the demand in terms of what we know is needed. And then I know there are a bunch of groups that have tried to give advice, from the CDC to the state departments of health, where they're trying to say, how do we prioritize? And the first two groups that they're talking about prioritizing are those who are at highest risk, frontline healthcare workers, EMTs, emergency rooms, people who are highly exposed, and then those who really get sick. And if we look at the deaths in the state, about 40% of our deaths have been from our senior centers. And how do we try to protect those communities that have the highest illness and death rate? And how do we do that? And how do we do it for the whole state, as quickly as possible, depending on the amount of vaccine available, which still is not clear to me, but I know that the governor and others have been working through that and sorting out an allocation. But those two groups were part of the recommended from the CDC highest priority. And then there are other groups right after that.
And the other thing about frontline workers, it's not just physicians and nurses. It will include our environmental workers in the hospital. Anyone that is front facing, anyone that has exposure to patients are going to be vaccinated first. And our hospital rolled out their plan today. And it's a wonderful opportunity if, people are willing to get the vaccine. All levels of employees will have access to the vaccine.
One last
Frontline
question,
workers.
Monopolize the time. I saw a story earlier and then it disappeared about thoughts about offering some sort of cash incentive for, I think it was for younger people or for lower income people to take the vaccine. And there were all kinds of pros and cons about that. And I guess I'm just wondering where you guys land on that. And then I will stop, Rich, I promise.
No, this is great. This is great. You're setting the tone, Tony. This is great. Stop.
I guess so. I'm not a distribution person, so I'm not as savvy and smart in these arenas as others are. But I think the idea of once we have enough vaccine, how do we get it into the communities that need it? And what are the different ways to do it? And I've heard similar discussions about different incentive programs. And the concept of we need to get the vaccine into the community to stop transmission, because there are a bunch of community members who can't be vaccinated for one reason or another, or don't respond to the vaccine because they have cancer and are getting treatment or having other illnesses that are being treated that may impact their ability to respond. So there's real value in having as many community members vaccinated as possible to try and stop transmission. How to do that is where the incentive plans come in. And I'm just not versed enough to know the right way to think about that. But the principle is very attractive, to get the vaccine into the community so we can stop transmission.
Yeah, I guess I would just add, Brookside is a perfect example, right? What they did with the community and partnering with the community. They weren't handing out cash, but they were handing out food. They were handing out voter registration. They were handing out access. It's the recognition that COVID is one of many issues that people in the community are facing, and trying to support more than just the vaccination, which is the an important issue at the time. To whether it be cash, if there's a mechanism to do that, whether it be food, whether it be partner, housing advocacy at the time. But I'm fully in favor of incentivizing in some way, because I think the people most at risk, frankly, really need it as well.
Sure. I was hoping to call on Gloria White-Hammond, Pastor Gloria, who's on and has another comment I think would be important to share, a question that I've actually seen a few times now in the chat. And so hoping that she could maybe sort of summarize that for folks and ask you guys a question.
Sure, thanks so much. I appreciate this forum. I'm glad to see so many people on the call. And I appreciate, Paulette, the reference that you made in terms of the kinds of equity reforms that are going to be incumbent on the part of healthcare facilities. Oftentimes people talk about the mistrust that is rooted in the history, which is absolutely true, but it's also lived out every single day in the lives of people of color who can tell you today. I have stories today of Brigham and Women's, Dana-Farber, Mass General. These are contemporary stories that are familiar to us. So it is historical, but it is experienced today. And so when you allude, Paulette, to the idea of not only redressing the history, but addressing the contemporary experience, let's look at equity in our healthcare facilities. Let's look at the extent to which racism continues to be embedded in the way the work is done. Let's look at boards, let's look at staff, let's look at promotion, let's look at reforms that are attached to accountability. And then we begin to develop a sense of trust. I think it's also important, I'm curious to see with pharmaceutical companies, because we are also hearing about the massive money that people stand to gain as a result of their vaccines, and it's wonderful. And people absolutely, but where is the accountability in terms of equity, even in as pharmaceutical companies? Because we know it's not all a rosy picture, right? I've got methadone mild a few blocks down from here. So we know pharmacists, as wonderful as they are, that there's another piece of the story. And so how do we, as long as we're having the equity conversation, which we should, how do we make sure that people get beyond well-crafted solidarity statements and so that we can really see the kind of substantive reforms so that the next pandemic, maybe we're not talking about trust issues in the same way. So that's my latest rant.
I love it, Pastor Gloria. Thank you. You guys have comments on that? And I you know, I'm very honest in with the people we bring on here and everyone who joins. Like, none of us have all the answers to this, and you know, it's just the fact of being here and actually discussing it and sort of having these difficult dialogues that I think is important. And so, you know, would welcome any comments from, you know, Paulette, Lisa, Lindsay around that issue. Like,
that's what some in the community are quite disturbed by, all the money that's been made by these companies, and they want to see greater investment in the communities of color that have been economically disadvantaged for centuries. And what does that look like? Some are saying, well, number one, more job training. Number two, making sure that your boards are diverse. Number three, thinking about actually investing in maybe housing in these communities, since housing is a big issue. But improving the financial condition of the communities would help greatly. And of course, the Brigham is really starting to think about that around social justice, and we'll see how it's operationalized, though. That's the key thing. And the community should hold us accountable. And hopefully these dialogues, as we get more out into the community discussing these issues, we will come up with viable plans. I know we're thinking about how do we involve like our artists and our the creative works type of individuals in talking about the vaccine and talking about health, wellness. And so there are a lot of different avenues to go in terms of bringing more equity into the community and how we deliver healthcare, the whole person.
So, I mean, I think that the inequity existed before COVID, and it's going to exist after COVID. And I don't know that COVID caused it. It just helped expose it. And I wonder if by pushing each other, it can also help address it a little bit, because we do need to realize that we are one community. This virus doesn't discriminate. And so that if we don't control it in every community, then every community is vulnerable. And so it is an opportunity for us to sort of realize we really are connected. It's the same bugs for all of us. And if we don't control it in all of us, then we're all vulnerable. And maybe it can help us come together a little bit, because the response really has to be coordinated.
I guess I would just add that, you know, my hope for this, you know, Lindsay, you're exactly right. Inequities have existed for a long time. So just looking at infectious diseases, you know, the disparities that COVID supposedly uncovered, you know, we were seeing in the communities of color with HIV. with tuberculosis worldwide, which is a disease of the poor. So when COVID also became a disease of disparities, it wasn't surprising. It was like, oh, banging ourselves in the head again. And the question I think a lot of us have is, what are we going to do differently? How can we? The conversation is now happening. I mean, this year for all of the horrible things of 2020, this conversation is now happening in around tables where it wasn't, right? So how to keep that going? I don't have the answer, but I just hope it does, that these types of conversations continue and the vaccine rollout helps us get out into the community more and really try to institutionalize these changes that we hope can be made. The Brigham is doing a lot right now with regards to looking at inequities and looking at diversity and really trying to hold different divisions accountable for, if they say that then equity and inclusion is important, what are you doing about it if it is? And I hope that will continue.
It's true. And I think that, I sort of point to all three of you too as people who are doing that work of keeping, holding the institution accountable. I know there are many people within sort of those four walls that are doing a lot of work to hold the institution accountable as much as possible. I think one of the challenges obviously is that we're going to have a limited supply of vaccine to start. And not everyone's going to get it. Not everyone who thinks that they should get it is going to get it. And so, I mean, I guess maybe just starting off by sort of refreshing, like, what is sort of the distribution plan? Is you guys understand it now? Should communities of color be prioritized to get the vaccine? Is that the right way to sort of think about it, or sort of bucketing people? Is that the right way to do it? Like, how are you guys thinking about that?
Well, I think that getting Wanda, there are members of our community who are part of the state's planning for this, of which I'm not, and so I've thought a lot about it, and I didn't know Paulette till 6 months ago. And we got to know each other because when we were launching how to do these studies, it was so important that we figure out how to do it better. And Tony, your point, that is 10% a success or is 10% woefully inadequate? And you're right. But our view was we have to do it better and we have to build teams to do it better. And, terrific relationships get born, and we try to figure out how to do it better, and we make mistakes and we do some things right and we learn, and then we try to iterate and do it better the next time. And so in how to do these studies, how to show these things work, how to try to start to address some of the vaccine hesitancy and suspicion and concern, I think we've trying to make steps in the right direction. To the bigger question, Rich, of how is the state going to roll it out? They have a plan that they're looking at. And as I said before, I know the priority issue is the frontline workers, and it really is anyone who is patient facing. Anyone who's patient facing of any kind, that's one group. Then the other group are the people who get sick in a hurry and die. And I know those two have been the ones that have been prioritized. After that, then there are a series of other groups who are at high risk. Because I know to just get our communities open, if we don't get our teachers vaccinated, and then there are communities that have had overwhelming amounts of infection that really need to be prioritized, because that's where a lot of infections going on. And so there are a variety of different stakeholders and groups that are debating this issue. Ultimately, until we have enough vaccine, it's going to be hard to know how they work down the priority list. And how quickly things can be done. And I hear different stories on the amount of vaccine, so I no longer know how much we're going to have in the next month for the nation and then locally. But I think it's in the tens of millions to 50 to 100 million, hopefully, in which case then we can have a really good debate about how to get it into as many communities that need it as possible. But it's hard to have that debate without knowing the supply.
I think, I think there's this tension of, do you prioritize using the vaccine to prevent deaths, or do you prioritize using the vaccine to reduce transmission and giving it to essential workers? And I think that, like, we don't have, I mean, that's a bit of an ethical dilemma, right? That nobody has like the exact answer to, but I think it's just important to name the dilemmas that are out there and say that, like, you know,
I completely agree, but to me, part of the dilemma is if my kids can't go to school, I can't go to work. And then what are the consequences of their education of not going to work? I mean, so I see a lot of interconnectedness that needs to be addressed as part of the solution, because I'm a little bit biased in that I really don't like people dying and going to the ICU, and that, just from my own personal experiences caring for patients here. But I can understand the debate because the ripple effects are very broad. If you can't go to work, then that has huge implications on food, education, all sorts of very basic things that your family needs. And I think we have to think about that as part of the equity conversation and part of getting society back to some functionality.
And of course, with the loss of jobs, some people don't even have jobs to return to. So that's where, these big companies need to be thinking about how, yes, they've developed a great vaccine, but what about the other aspects of the economy?
Yeah, I think just being thoughtful about how you sort of classify people generally is really important to think about. And I know that you have to have some sort of way to categorize or classify people to distribute something that's of limited supply, but making sure it doesn't reinforce biases or stereotypes, and making certain I just think it's being thoughtful is important. And I know that none of us are sort of in charge of exactly how this is rolled out here in Massachusetts, but just bringing awareness to sort of all the different ways that this needs to be parsed out and thought about is really important. And so I know that we're coming up to sort of to age 15, and I want to be respectful of people's time, but I have, as a sort of transitioning to, like, next steps with COVID and sort of looking beyond, I guess one thing I wanted to ask is if you think be a little creative here, like what if I had to ask you sort of your best idea for like a concerted public information campaign, right, to convince Americans, particularly communities of color, right, that they should get vaccinated and that the vaccine is safe, what would you say?
Stop the epidemic of disinformation. Facts, we need to at least agree on facts. We may interpret them differently, but I just think there's so much confusion out there right now that I can understand how everybody's suspicious of the information.
There's been, some work done on what messaging is effective, and Bisola and Dr. Weintraub are also working on that. And one thing is that, we all need to be part of the solution. We need everyone to be on board to bring an end to the pandemic. So that sense of community and unity, of course, it may be difficult to feel the unity and part of the community if you've not been considered to be important and valued as a member of the community. But we do need to be working together, and everyone needs to be involved in this problem, solving the problem.
Sure. Yeah, it's definitely it's an issue that has the potential to be divisive and further sort of cement, as I said, certain cement divisions in society in a lot of ways, but it also has the potential to be quite uniting. And I will say that at least in my work that I've been doing, I've seen a lot of people from the community who either did go into the vaccine trial or very adamant about getting the vaccine and been wanting to help and wanting to be ambassadors of truth in their own communities. And so I think the more that we're able to bring those people to the forefront of this important work, the better. Because again, like, yes, the Brigham has a ton of, and all these hospitals honestly have a ton that they need to do to sort of build better trust in the community. But ultimately, I think the best way to do that is partner with the right people who already have the trust, and have them be sort of the flag bearers of truth. So I guess one last thing that I'm sure is on people's minds is holiday season is upcoming. okay? Like people who are understandably, weary, eager to mark to mark the holiday season with some joy, right? I think that's appropriate. I guess how would you advise them? I'm sure, Paulette, maybe you're having conversations like this in clinic. Like, what would you say to people right now, in this sort of transitory time, before a vaccine is really available, but in the middle of this surge right now, and people really do need some joy?
Yeah, I mean, I echo Lindsay's recommendation. Try to limit your contacts, stay close to home, embrace your family, enjoy the season. There are a lot of things that you can do as a family, and if you don't have family members, you can still connect outdoors. You can do things outdoors, physically distance, but I would not do a lot of indoor activities with a large number of people, because that's where it really spreads. And so most of my patients many of them are quite comfortable with just staying within their home setting, connecting with family members that are in their home, or if they are living alone, then using social media or going outdoors and connecting physically distance.
I mean, I guess I would say we're all exhausted. I think the vaccines are coming, and the allocation discussion we're talking about is a timing issue, not a ever access issue. How to get the vaccine in the first 2 months versus 4 or 5 months from now. But as it gets deployed, then it will hopefully have a dramatic effect on transmission. So I just, for the next 2 months, in my own mind, for my own safety, it's like, how do I be antisocial? And I am just saying that is, how do we minimize that physical interaction because of the high risk of spread for the next 2 months? There really is a light at the end of the tunnel, in my view. I think is highly likely. And so how do we minimize how do we go that little extra distance, we're mile 24 of a marathon, we're totally wasted. But there is a light at the end of the tunnel, in my view. It's just, I think it's going to be a dangerous 2 months because of the amount of COVID in the community, and it's spread by person-to-person interaction. And how do we help redouble the efforts to just say, be careful for 2 more months, which means Christmas and New Year's spend like this. It's not very fulfilling to do a Zoom, but I think that, I haven't seen my father in 10 months, and I'm not going to see him in the next 2 months. He's in his 80s, because if he gets COVID, he's in a very, very high risk group. And so how to keep him in a bubble for another 2 months until the vaccine supply, which we'll know in the next month how it rolls out, will help, start to turn the corner. So I don't know if that helps, Rich. I just think I'm worried about the next 2 months because the amount of transmission and the amount of exhaustion we all have. But this is different than 6 months ago, when there wasn't an intervention to make a difference. There is an intervention to make a difference that's long lasting, that is coming, and it's a matter of coming in 2 weeks or coming in 2 months. But once it comes, it should have a big difference in the risk.
Right. Yeah, and I think that having this light at the end of the tunnel, a bit more visible now is really important, and hopefully conversations like this bring some solidarity. I think, which is important for people to feel like they're not just in their own struggle trying to sort of deal with this on their own. Like, I think the more we can use these wonderful technology to bring people together to have these conversations is hopefully provide some boosts of motivation for sort of the next few months for people to really hunker down and do what they need to do as a sort of responsible citizen of the world, really. And I think I wanted to, before we get off, I wanted to shout out to Ted, who's one of my good friends who comes to all of our CCW events, who basically gave this idea that, like, for this campaign, is like, could we make sure that we have patients and doctors who both video and talk about their experience with getting the vaccine when they actually do it. And so I think, that's just another great idea, Ted, that I think we'll figure out how to do that through some of our CCW work. But I would encourage people, when they do have the option of getting the vaccine and they do get it, to make sure it's not just about them individually anymore, right? It's like, how do you how do you act as a promoter in your own community? And so, Ted, I want to, thank you for those words of wisdom at the end, and I want to thank all of you for joining tonight. And again, it's a pleasure to have these conversations, and really appreciate Paulette, Lindsay, and Lisa for being here to help guide us through. All right. So with that, I'll bid you all good night, and thanks for joining.
Thanks so
Thank
much.
you.
Good night,
Thanks
everyone.
so much.
Good night.
Bye.
Take care.
Bye, everybody.
Bye.